Well, good afternoon. I'm going to wait just a couple more seconds before we get started, just so that everybody can join our webinar. Right, well, I think we can get started with the introductions. So good afternoon, everyone, and thank you for joining. And my name is Sandra Vandenberg, and I'm a professor in behavioral science and health promotion at the UT Health School of Public Health in Austin. And I'm also the associate director for the Michael and Susan Dell Center for Healthy Living. And today's webinar is co-hosted by the Michael and Susan Dell Center for Healthy Living at the UT Health Houston School of Public Health and the Texas Consortium for the Non-Medical Drivers of Health. And our center's, the Michael and Susan Dell Center's vision is healthy children in a healthy world, and with a vision to advance health and healthy living for children and families through early and impactful interventions. We can go to the next slide. Our co-host, the Texas Non-Medical Drivers of Health Consortium, is a convener for researchers, practitioners, and policymakers that aims to accelerate the integration of non-medical services into the healthcare delivery system in Texas. The Texas Non-Medical Drivers of Health Consortium is an initiative of Rice University's Baker Institute for Public Policy and is a resource to support Texas policymakers with information and resources on health topics during the interim and throughout the 89th legislative session. Next slide, please. And I just want to acknowledge the Michael and Susan Dell Foundation for funding and providing funds through the center to host today's webinar. Next slide. And additionally, there is some information on this slide regarding our center's work and some resources that you can find online. And you can scan the QR code on your screen to access those health resources. Also want to mention that the slides and the recording of today's webinar will be archived on our websites, the msdcenter.org and driversofhealthtexas.org. If you have any questions during the presentation, please enter them into the question chat box for the Q&A session at the end of the presentation. Next slide. All right, so with that, I am really excited to introduce today's speakers, Dr. Elena Marks and Dr. Charles Mathias. Dr. Marks is a senior fellow in health policy at Rice University's Baker Institute for Public Policy. Her work focuses on reforming the $4.5 trillion health delivery system so that it produces positive health outcomes, not just more medical services. This work includes incorporating the delivery of and payment for non-medical interventions into the system when appropriate to improve health and the value of health spending. Dr. Marks has been affiliated with the Baker's Institute in a variety of capacities since 2010. Previously, she served as the founding president and the CEO of Episcopal Health Foundation, a $1.3 billion nonprofit, from 2014 to 2022. And also as the Director of Health and Environmental Policy for the City of Houston from 2004 to 2009. Early in her career, she practiced law and started, built, and sold a successful law-related business. So we're very happy to have her for this webinar. And then our second presenter is Dr. Mathias, who is the Director of the Consortium for the Non-Medical Drivers of Health at the Rice University. Dr. Mathias's work has focused on health conditions like mental illness and substance use that are frequently accompanied by significant non-medical needs. He focuses on the critical role that policy plays in creating effective health solutions through his service as a Robert Wood Johnson Foundation Health Policy Fellow in Washington, D.C., working on Medicaid policies. Prior to joining the Texas Consortium, Dr. Mathias spent 20 years with UT Health as a behavioral health researcher. So I'm also very, very happy to have Dr. Mathias join us today. So I'll now hand it over to Dr. Marks and Dr. Mathias with their presentation on non-medical drivers of health, policy options to improve healthcare quality.
Thanks very much. We're honored to be here today with you and excited to be speaking to a public health oriented audience because you will get what this is about. So next slide, please. I'm going to start out by framing the conversation that we're having at the Texas Consortium with background information, a lot of which ought to look really familiar to a lot of you. And then Charles is going to take you through some very specific examples of how we can actually improve health outcomes by incorporating more non-medical services into the healthcare delivery system. So the slide you're looking at now, if you're a public health person, you've seen this a million times. It comes from the Robert Wood Johnson's Foundation's county health rankings, and it represents decades of research that has attempted to allocate drivers of health so that people can understand what causes people to live a long time and the quality of their health while they live. And the thing that stands out to all of us in the public health space about this is that medical care is only 20%. There's another version of this that the National Academies has used that shows medical care is only at 10%. And so while medical care is really important, it's really not the largest driver of our health outcomes. Next slide, please. So what you're looking at on this slide is on the column that says drivers, that's the previous slide just reorganized. On the right-hand side, you're looking at the expenditures. These are our national health expenditures from 2022. They total to about $4.5 trillion. And the size of the type and the color reflects where those dollars are spent. And so of that entire national health expenditure budget, that includes government spending, business spending, individual spending, we see that 95% of it goes to clinical care, and only 5% of it is going to public health, which loosely correlates with the health behaviors. And the reason that it's even as high as 5% is because we had a COVID bump. For decades prior and probably going forward, that number tends to be about 3%. So what you see is that we are spending the vast majority of our national health budget on hospitals and then providers, and then it goes down from there. Other countries do things differently. And let's take a look at how they spend their resources. So this is a chart that shows you information about several wealthy OECD countries. And each column represents the percentage of GDP that country spends on healthcare, health spending, which is in the green, the top part of each bar, or social spending, which the OECD refers to as a whole broad variety of services that are health impacting, but that they aren't health care. And so when you look at this chart, and the US is the column on the far right, what you see is that we're not an outlier in terms of total spend. We're on the high side, but we're not the highest. But what's different about the US than all these other countries is the proportionate spend. We are the only country that is spending more on health than on social. And if you look at our ratio, it is not only lopsided, but completely the opposite of all of these other countries. Let's go to the next slide. And when you look at this, same bars, but you overlay health outcomes on top of it, you see that our expenditure pattern does not lead to the best health outcomes. This line, the red line, shows you life expectancy in each of these countries. As you can see, we're the worst. Next slide. This is asthma hospitalizations. We are the worst, and the little blip from Australia, Charles will explain to you later on. Next one. The obesity rate, this is not a surprise to anybody here. We have a much higher rate of obesity than other developed countries. Next. So how do we change this dynamic? What can we do about the fact that we are spending more than any other developed country on healthcare, and yet the outcomes we're achieving far below these other countries? Let's go to the next slide, please. So this is a framework that we use because it gives you a good idea of understanding the relationship between health investments and health impact. And excuse me, it was published in Health Affairs some number of years ago, and it has really stuck with me as a good way to talk to people about how you look at investment and impact. So if you start in the downstream part of the stream, you see we're talking about a medical model where there are medical interventions. You're providing only clinical care, and you're doing it one person at a time. And while it's important, we need to do that. We all need access to individual health care. The impact is not quite as great. If you move to the middle of the stream, we're still talking about individual impact, not impact at the community level, but you're opening up the tools in the toolbox much more broadly than when you're just talking about a medical model. So in this midstream, we can talk about how we broaden the team and broaden the services that are made available to people so that it's not just clinical services. And that's what we're going to spend a lot of time on later in this presentation. How do we get within our individualized healthcare system more services directed toward these midstream opportunities? And of course, if you're a public health person, you're living in the community impact, the most upstream, where if you change strategies and policies and tactics, you can change the trajectory of entire communities. And so this gives you a good way of looking at if you use these investments in this way, what is the outcome or impact that you're likely to achieve? Next slide. So what we're going to talk to you about today is how Texas can do a better job of using its huge investment in healthcare by changing the way it spends some of those dollars. This all comes from a report that we published earlier this year, and we'll have a slide with a QR code to it later. But what we did was take a look at the entire state's budget and pull out of it some healthcare programs that have big bucks behind them and the opportunity to perhaps improve outcomes if they direct some of those clinical care dollars to some non-medical services. So the way we broke it down is first within the Health and Human Services Agency and their programs. The biggest bulk, not surprisingly to anybody on this webinar, is that most of that money is in Medicaid with a little bit in CHIP, which is its companion program. We also have more than $1 billion outside of Medicaid that goes to mental health and substance use services. And those are populations that can really benefit from non-medical interventions. We also have $150 million devoted to women's health and thriving Texas families. And these are services for low-income women and their families and young children. And it's a perfect opportunity to intervene with non-medical services. So in addition to the healthcare programs that are funded by the state directly for Texans, the state is also a very large employer, and so it has its own employee retirement system, which provides benefits for our colleagues, our friends at UT Health and other state agencies and state universities. And the state puts in $2.7 billion a year toward the healthcare plans that these employees and their family members use. It's the same thing, the teacher retirement system provides more than $1 billion each year in state dollars to support the health plans that public school teachers have. And if we can change how we spend some of these dollars, we think we can increase the value in the outcomes that these organizations can produce. And there are lots of policy options. I'm not going to go through this in any detail other than to tell you that read our paper, but there are lots of different ways to approach this. If you start with Medicaid, which has the biggest expenditure, over $40 billion a year, there are various kinds of waivers. There are in lieu of services authorizations. There are CHIP Health Service Initiative opportunities. There are opportunities with MCO quality incentives. There are directed payments programs that are paying providers billions of dollars each year for quality improvements, and their reporting and evaluation opportunities. Our report goes into a lot of detail on how each of these strategies could be used as a mechanism to move some of those medical dollars upstream to provide non-medical services and produce better health outcomes. In the case of other state revenues, we've outlined again these same opportunities that can go hand in hand with the teacher health plans, the employee health plans, the women's services, and our mental health and substance use investments. And I'm going to turn it over to Charles, who's going to take you through the rest of the presentation, where he's really going to drill down into how you can do some of this work in a way that's meaningful for Texas. So Charles, it's all yours.
Thank you, Elena. So through this presentation to this point, this has been rather conceptual, but what we'd like to do is talk to you about some practical applications of this approach. And to do that, we're going to talk about two health conditions, asthma remediation and food interventions for kidney disease. Earlier, Elena showed that we're really an outlier on a lot of these health outcomes that we're getting. For the note that she made about Australia having a high level of asthma that was approaching ours, they have two unusual factors that drive that. One is they have very large annual wildfires in their grasslands, so there's a lot of exposure. And then secondly, they have a high immigration from Southeast Asia among folks who are not used to the environmental allergens that are native to Australia. So those are two factors that cause them to be a little bit higher. So what does asthma mean for Texas? Most of us are familiar with asthma conditions. It's a narrowing of the bronchial pathways that can cause a shortness of breath. And we've probably seen people with inhalers, and it seems like, no big deal, right? But it actually affects a fairly high number of Texans, almost 500,000 children, half of which are covered in the Medicaid and CHIP program. And some people, well, many people can have their asthma controlled very well. For some, it can become more difficult to keep that in check, and they can have a very strong reaction. We have almost over 90,000 hospital or emergency department visits per year due to asthma attacks, and over 7,000 hospitalizations. It costs us, the state, $930 million. So this is, relatively common, relatively expensive condition that we face, and that's heavily covered in the Medicaid program. So if you look at causes for asthma, there's really three factors: exercise, occupational, and environmental. Exercise causes for asthma attacks are really well controlled. If we work with children to learn how to manage that and how to use an inhaler, exercise can become well controlled. Similarly, occupational exposures are really heavily regulated by OSHA and other workplace safety measures. So the third factor, environmental triggers, are the major cause of uncontrolled asthma and asthma attacks that require healthcare. And I have a couple examples on the screen here. There's things like mold, pest dander, and dust that can cause these triggers, and the home in particular is the most likely location to have these exposures just because of the length of time people spend in their home. So due to this, the home being the main source of these exposures and triggers resulting in need for medical care, the Texas Department of State Health Services has a strategic plan for asthma control. And part of that plan focuses on home visits, where a trained professional goes into the home. Lots of times these can be community health workers, where they can assess the home for triggers and educate the family on how to get those triggers out of the home. And the plan really focuses on training a workforce, making sure we have enough community health workers or other professionals that can perform these duties, but also how to integrate these home visit services to clinical care, the medical electronic health record, and also they're focused on addressing sustainability, where they really want to work with the managed care organizations and even employer-sponsored health programs to find ways to fund this. But this is not a item that's implemented right now. It's kind of more aspirational and a plan for how we can work towards sustainability. So home visits are demonstrated by data to be effective. And a challenge for them is what happens if a family doesn't have the capability for removing the identified trigger that's in the home. So a solution to this is something called remediation programs. The way these programs work, on the figure here from left to right, you see on the left-hand side, usually in the electronic health record, we can identify those patients who are ending up in the emergency department more frequently and having uncontrolled asthma. That can trigger us to then initiate a home visit program to identify those triggers. In some cases, the families themselves can remove those, but in other cases, if there's something more complex like mold in the household or a need for carpet removal, there's actually programs, home remediation programs, where professionals can come in and get those out of there with the purpose of stopping the cycle at the beginning and making those triggers not be present to cause attacks in the first place, and which would help avoid the need for future medical care. And then what we really want to do in these programs is, if we have a remediation done, we want to tie that back to electronic health records so we can monitor to see how things change for those patients. This is a plan that was recommended in the last session by the Texas Value-Based Payment and Quality Improvement Advisory Committee. Before each session, this committee makes recommendations to Health and Human Services for their plan with the legislative branch. So this is an approach that's pretty widely endorsed. And there are some kind of pilot program examples of this already operating in Texas. One program in San Antonio called Kids Breathe program involves community health worker visits to homes to educate families and connect them to remediation services and report home assessments back to the electronic health record. On the left-hand side, you can see we can kind of formulate and scope the size of these programs pretty technically. You can see this program identifies children 13 to 17 with asthma and certain criteria that demonstrate they have a significant level of uncontrolled asthma. They're ending up in the ER frequently. They're having hospitalizations or missing a significant amount of school. So that's how they kind of identify eligible participants here. The funding for these comes through a variety of sources. The Department of State Health Services Excel grant. There was some money contributed by the San Antonio Metropolitan Health District, which is the public health department. And then the remediation services are funded through the Green and Healthy Homes Initiative. Since 2019, they've done over 400 home visits. And what we have seen is that while people at entry to the program, about 3/4 of them have uncontrolled asthma, that rate drops to 37% by the second visit by the community health worker, and by the end of the program, the 12-month follow-up period, only 8% of participants are still having issues with uncontrolled asthma. Now, other states have seen the value of this approach and found ways, policy mechanisms to make these sustainable initiatives. There's a couple examples I've highlighted here, and they've used different kinds of approaches to make this happen. In Wisconsin, they've used the CHIP Health Services initiatives. In California, they use something called in lieu of services. And in New York, they use a value-based payment models. I'll give one example of these state programs, the Wisconsin program called Asthma Safe Homes. Again, you can see on the left-hand side, the eligibility of this program is focused on children in Medicaid and CHIP who are ages 2 to 18 years old, but also the mothers of those children while they're pregnant if they were covered in the Medicaid program. As I mentioned, their funding for this is through the health insurance, the CHIP health insurance program under a state plan amendment. And what this does is it allows home visits to educate the family, do what they can to remove any triggers, but if they identify a need for remediation, they can have outside professionals come in, and this program, the CHIP program itself, pays up to $5,000 to have remediation done for things like mold. This has been very successful in terms of outcomes. They found that almost 80% reduction in emergency department visits and a halving of hospitalizations. Importantly, because this is focused on children, they had 87% fewer missed days of school. So really getting very strong outcomes for participants in this program. So one opportunity that we highlight for the 89th legislative session is just to direct the Texas Health and Human Services Commission to explore the provision of asthma trigger remediation through home visits. And we identify a couple different mechanisms. Some of those we were just talking about, including the Medicaid and CHIP program and in lieu of services for the managed care organizations. Moving on to food interventions for kidney disease. This is another relatively common, highly expensive, and a condition with demonstrated evidence that non-medical interventions are effective. Kidney disease in Texas affects only about 3.5% of adults, but it can have devastating consequences for the health and the costs associated with those health consequences. We have about 72,000 persons experiencing kidney failure and about 4,700 die each year. This is the 10th leading cause of death in Texas. It costs about $85 billion in the US for Medicaid costs. And in fact, the Medicare program, about a quarter of their overall spending is just on kidney disease alone. So if we can prevent someone from needing dialysis or going on to kidney failure or needed a kidney transplant, we can save about $250,000 per patient. So we have a state health plan for this, and that health plan, kind of based on the figure that Elena showed before, focuses downstream. It really is a plan for addressing end-stage kidney failure where people need either a transplant or dialysis. And what we're really interested in is and that's important for sure for people who've gotten to that point, but there's a larger group of people who have kidney damage but haven't reached end-stage failure. For those folks, we're very interested in moving midstream to that individual impact where we can think about how to use food interventions like medically tailored meals to prevent the progression of kidney disease. Texas has been a leader in this. In fact, some of the evidence bases is established right here. This was a 5-year RCT that was done here in Texas that looked at medically tailored groceries delivered to kidney disease patients by community health workers and they met them in their faith-based settings. So that's what kind of made this a non-medical intervention. The fact that not only are we giving them food intervention, but we're using part of the workforce to meet people in their own communities. And this food intervention was compared to either treatment as usual or treatment as usual plus a dietary supplement that mimicked the fruits and vegetable produce intervention that was in the food side. In the lower left-hand side, what you see is that the progression of kidney disease, which would be lower on the chart, the usual care only had a faster progression of kidney disease across 5 years. Both the food intervention and the supplement group delayed the progression. Their kidney damage was less over time. However, the food intervention group in particular had a unique benefit besides just the delayed progression. They actually had reduced cardiovascular risk, which is shown on the right-hand side of the screen as their systolic blood pressure and their plasma cholesterol across time. So overall, the conclusion was this food intervention that was delivered by community health workers was the superior health outcome that we were looking for across time. So if we look at like kind of cost savings for these kind of interventions, we can get an idea from a slightly different area, which is diabetes. This is not kidney disease, but I'm showing you diabetes because diabetes is actually the #1 cause of kidney disease. And we can see in this figure, just on the top white row there, the Medicaid program, there's about 346,000, almost 350,000 adults in Medicaid with diabetes, and we have about 63,000 hospitalizations per year from this condition. This estimate shows that on the right-hand column, the net savings from doing a food intervention using medically tailored meals for these folks could save the Medicaid program about $1.4 billion, even after accounting for the cost of delivery and the cost of the food itself. So that's a significant savings. And you can see for Medicare program, it's almost double that savings. This next example is a collaboration between Factor Health, the Dell Medical School, and Harris Health in Houston, and it's a food delivery program working with folks who have kidney disease. And you can see on the left-hand side, their eligibility is to identify people in stages 2, 3A, and 3B of kidney disease. So they're showing kidney dysfunction, but they haven't progressed to the point where they have kidney failure yet. And so the idea is if we can grab folks earlier upstream in their condition, can we delay that progression of needing more intensive medical interventions? These are primary care patients within Harris Health who are adults and identified through the electronic health record. This is funded by a foundation, the Episcopal Health Foundation. And what they are observing is that they can show a 10% improvement in kidney function within 6 months with this simple dietary intervention. Now, 10% might not sound like a huge amount, but remember, a lot of these chronic conditions, if we're going to manage them through nutrition, it can take them longer to see the impacts. So 10% in 6 months is actually very quick. And a 10% improvement is important because this is a condition where you're actually typically seeing a decline in function. So even if we're keeping people steady, we'd be stopping that progression, but in this case, they're getting better. What that costs or represents in dollars is there a savings of about $1,900 in medical visits per year for those patients. And if we can stop that progression and not get them to stage 5 kidney disease, we can save $50,000 a year in what they would experience in needing to go onto intensive care like dialysis or transplantation. So in the 89th session, in looking at opportunities, there are a lot of different ways this kind of program could be funded. Last session, a bill was introduced that used the 1115 waiver mechanism. That is still one of them. You can see that's one that probably is most likely used. There's a list of states on the left-hand column here, and next to it is those who have waivers for food interventions. You can see these are used in large states and small states and red states and blue states. So it's a pretty widely embraced approach. But besides the 1115 waiver, which Texas has one, we have other levers, including in lieu of services, where you can substitute a non-traditional intervention if it's going to be cost effective in avoiding future medical care needs. And then there's also ways we can incentivize managed care to make these kind of programs happen. So in conclusion, the point of our report is just that investing in non-medical services to prevent and manage chronic disease can lead to better health outcomes. It's just a smarter way to use the health care expenditures that we have. And we encourage the legislature to embrace and look into these kind of interventions that can save dollars for the state and make Texans healthier. With that, I'll point you to two important resources. On the right-hand side, there's a QR code that shows the full policy report that this presentation was based off of. And on the left-hand side, if you're interested in these kind of topics that you heard about today, we would love to have you join us at our annual conference. This is in Houston on Thursday and Friday, December 5th and 6th at Rice University. There's a QR code there that shows registration for the conference, and my contact number is in the lower left-hand corner. With that, I'll turn it over to our Q&A.
All right, thank you so much, Dr. Marks and Dr. Mathias, for this great presentation. We can now answer any questions from the audience. So if you have a question, please put them in the chat box. And while we're waiting, I have a question. I hope that's okay. I love the food interventions for the kidney disease, the examples that you provided. And I'm curious for the first one that you discussed. I would love to know more. It looks like it was a statewide intervention or program. And I'm just curious. Yeah, let's see. That one, yes.
This?
Yeah.
All right.
No, not that one, the one before that.
Oh, I'm using my arrows wrong here.
Yeah. Do you know, were y'all involved in this particular study? And if not, do you know who delivered it?
Yes, in fact, we were not involved in it. This is from a relatively recent publication, just came out this year. And if it's okay with you, I could share that resource and you can maybe add that to the resources that you post online.
That'd be great. Yeah, I mean, these results are pretty amazing, I think.
Yeah, 5 studies, and it's incredible.
Yeah, no, absolutely. Yeah, I'm just really curious, like how long each participant received the groceries. Was it really over a 5-year period, or was that just where these just, anyway, if you can provide the resource, that would be awesome.
We'll share that out. Thank you.
All right. And I do not see any questions yet. Let's give it a couple seconds.
So one of the questions that we often find is when people ask about in terms of policy solutions, like how to scale these solutions to a size that's manageable, because we know in the policy space we're always sensitive to like what's the budgetary impact of them. And you can really as you saw in these examples, you can define the patient population really accurately just from information that's already available in the electronic health record to kind of determine how many, what level of severity you select, and that kind of determine, how many people might qualify from the program and where that, we know like it's that really small number of cases that drive a lot of those costs. So if we can take care of, a relatively small proportion of the folks experiencing the condition, we can actually do quite a bit to, avert a future health cost. So that ability to scale that, I think, is an important consideration when we're designing policy solutions for health conditions.
Okay, I do have some questions coming in. One of them is, do you have any insights on how to partner with the private sector to influence outcomes?
Elena, I know you've had this one before.
Yes. So I'm not sure exactly which parts of the private sector you mean. In this space, in the food space in particular, there are for-profit companies that do this work. And frankly, once there's a revenue stream for the work, you will see a lot more organizations, nonprofit and for-profit, stepping up to do the work because there's a sustainable funding stream for it.
Okay, yeah, thank you. And that's, very true. And yeah. Okay, another question that we see here is, and this is going back, I think, to the project I was asking about. Was there education around the grocery delivery as to how to prepare and use the food? So in addition to just the delivery of food, was there any other components?
Yes, I believe that was one of the reasons why they used the community health workers, because it was more than just getting the food to them, but also having that connection with a trusted member of their community where they could talk about, what's culturally appropriate for how to use and prepare that food. Because we know when we change the food for an individual like someone with kidney disease, it kind of affects everybody else in the household. So how to navigate, everybody kind of adopting this new lifestyle.
Thank you. Here's another interesting question. What role can technology play in making these interventions work? Are there still issues with sharing data quickly and easily across the community care team for a patient? Would be great to get city code departments involved to prevent evictions based on living conditions that need improvement. I don't know the second part, but I think the first part, right? What role can technology play in making these interventions work? And then the second part of that question, sharing data. How can that be done more efficiently or effectively?
On the sharing data part, we're starting to see two different kinds of things happening. One is there are platforms out there that aggregate all of the community-based organizations, where you can get food, where you can get rental assistance, legal assistance, all of that kind of work, and making that available to healthcare providers so that they have opportunities to make those referrals through a technology solution. Sometimes you can do it where it's a closed loop referral, where in fact the provider refers someone for, say, food, and they are able to track through that system whether or not the person actually received the food. The other thing that's going on is that some of the health information exchanges across the state who house all of this medical data from healthcare providers are working on solutions to integrate the non-medical needs along with the medical needs and include referral opportunities to service providers. You know, with medical data, we know the HIPAA and other requirements are different than they are in the social service sector in terms of confidentiality and privacy and security. I think we're seeing an increase in that work. I guess my caution would be it still takes people, that just because you can send a referral electronically doesn't mean that the person's actually going to get the service they needed. And as Charles was just alluding to, the reason that some of these programs work, it's not just that they got the food, it's that they had interaction with a person who is helping them, because otherwise you could have had it, you know, drop shipped by a drone. So don't over rely on technology or expect technology to do this for you.
And the legislature has recognized that, you know, in the last session, House Bill 1575, which is to improve health outcomes for pregnant and postpartum women, part of that plan was to do screening to identify non-medical needs, but also have case management and navigation so they actually get connected with those services. So just making sure they can get there.
Yeah, no, I 100% support the use of real people within these types of intervention referrals, etc. I think it makes all the difference. Okay, an interesting question. Which federal policies need to change and how would they need to change in order to facilitate state policy changes that would help support non-medical drivers of health? I realize that's a very big question, but maybe one example would be great.
So actually the feds are ahead of the state through Medicaid, the CMS, and this happened during the Trump administration and the Biden administration, and presumably will happen again, so that it's not partisan, has a lot of opportunities for states to make their own decisions to do this work within Medicaid, but states have to do it. Also on the federal side within Medicare, the Medicare Advantage program includes opportunities for all sorts of non-medical services. So I would say the feds are actually leading the state, and that the state, and I don't mean to say that everything's perfect at the federal government, because I'm sure they could do more, bigger, better, faster, but there are opportunities on the table right now that Texas could take advantage of. And that's what our report's really about, is they perhaps the feds could go farther, but they've gone farther than we have. Let's take advantage.
Yeah. Thank you for that answer. We have many questions now, so let me see. What would go into determining which downstream medical issue to address with these community-based interventions? And I'm assuming the medically tailored interventions. Does total medical spending usually drive this research, or are there strategies to address feasibility of change or medical spending efficiency first?
So we kind of talk about a three-part decision rule. You know, is it a relatively common condition? Is it a relatively expensive condition? And is there evidence that these non-medical interventions make a difference? And if you've got all three, then that's a priority item.
Could you give another example of, besides kidney disease, what would be another good chronic condition to address using these types of interventions?
Besides kidney disease and asthma, you know, before kidney disease, you'd be looking at diabetes, you can be looking at hypertension, you could be looking at stroke.
There's also a lot of opportunity in the mental and behavioral health space where people have need of clinical care, therapies, medications, but they have more needs than just that in order to fully recover and re-enter society. And so you see opportunities, excuse me, around supportive housing, employment opportunities. So anything, as Charles said, that's common and expensive, and where there are non-medical services that are known to make a difference, are great opportunities to start. And we encourage everyone to, like, don't wait for the perfect plan to pop into your head. You have enough data to get started. If you're a healthcare provider of any type, you ought to have enough data to know what your patient population looks like and what it needs, and then you go from there to figure out what do we do if we happen to have a lot of an older population and there's a lot of hypertension. What are the non-medical interventions that are most likely to make a difference in that space?
That's great, thank you. Question about funding. If funding streams for interventions like this seem like they may not be available, what are some alternative opportunities?
So that's really the point of changing policy. It's really to allow the healthcare system dollars to be used for some of these non-medical services. The way a lot of this is funded today is through grants. Could be public or private, but as everybody knows, grants come to an end and they are not a long-term sustainable source of revenue. And so it is our intent to help change policy so that there is support within the healthcare delivery and financing system for paying for this work. It's a relatively new field of practice, and we are seeing more evaluation take place to show that there's either a cost savings or a health improvement, or best case scenario, both. And the more evidence we have that these things are working for particular populations, particular conditions, the more likely we are to find long-term sustainable funding for it.
And as a new field of practice, we see tremendous innovation by providers and health systems and payers. And what we're just looking for is a policy and environment that can kind of keep up with all of the change that's already occurring in the community.
Right. Well, with this, it looks like we've covered, there are more questions, but they're very similar to, and I think you've addressed all the things that people are asking about, but there have been a lot of questions, so very appreciate everybody being so participatory. But I just want to say thank you for everyone for attending, and then of course, thank you to Dr. Mathias and Dr. Marks for presenting. Like I said earlier, the recording, the slides, and the resources will be posted on the websites, along with the information about upcoming webinars. And you will also receive a follow-up email with links to all of these. With that, I just want to thank you for joining us, and we will see you next time.
Thank you, Dr. Ramberg. Thank you, everybody.
Bye-bye.
Thank you for having us.